Hello, everyone. Welcome back, and welcome to the final session of the 2025 World Sepsis Congress. We are going to end on a high note, I swear. No, truly, we have an exceptional group of speakers to close out this Congress with, and we're going to address something that I think is absolutely essential. We're going to talk about survivorship and how survivors deal with recovering from sepsis. You know, as a sepsis clinical trialist myself, we get very excited when we say, hey, they survived. But we forget that that's not the end, right? Surviving is just the beginning of the patient journey with sepsis, and it can linger years and years into the future. So I think to date, grossly understudied and underappreciated element of the sepsis pathway and the sepsis journey. But I think one that our speakers here are really working hard to try and rectify and trying to add to our knowledge and our understanding of these effects in the long term. Oh, God, introductions. Myself, I'm Dr. Nathan Nielsen. I'm an intensivist and blood banker at the University of New Mexico, a longtime sepsis clinical trialist, and a proud member and supporter of the GSA for more years than I care to admit right now. So, without further ado, I'm going to get out of the way and let the experts do the talking. And our journey begins in South America, down in Buenos Aires. Dr. Iván Alfredo Huespe. I hope I got that close to correct. Just for introduction, Dr. Huespe is a critical care physician and the head of critical care research at the Hospital Italiano de Buenos Aires. And his specialization is developing causal and predictive models for mortality and its complications in critical care patients, particularly with a focus on sepsis. And he is going to be speaking to us all about how, or I should say, on predicting long-term cardiovascular complications following sepsis, an important sequela. So without further ado, Dr. Huespe, the microphone is yours.
Well, thanks a lot, Nathan, for the introduction. I'm the head of the research section here in the Hospital Italiano de Buenos Aires, the section in research in critical care, but also I'm an external researcher from the Mayo Clinic in Jacksonville, Florida. And today we are going to talk how we are working in the prediction of long-term complications, especially cardiovascular complications after sepsis discharge. And as we know, sepsis remains a significant global health problem. However, due to the medical treatment and improvement, the survival after sepsis is increasing. Therefore, right now, we are having a rising population of post-sepsis survivors. These patients, the 70% of them, will have physical, medical, cognitive, and physiological complications after sepsis discharge. But today, especially about the cardiovascular complication. After sepsis discharge, patients will have an increased risk of acute heart failure, myocardial infarction, and any kind of stroke. In fact, we know from Science 2024 that patients discharged for pneumonia, for example, have an increased cardiovascular risk that persists even 10 years after discharge. And it was published in 2021, a really interesting meta-analysis that found that patients discharged from sepsis have long-term cardiovascular complications equal to patients who have hypertension, dyslipidemia, or diabetes, even though several sepsis survivors have a twofold increase in cardiovascular risk, and that's important even between patients who don't have cardiovascular comorbidities previous to the hospitalization due to sepsis. Well, the causes of this increased risk are right now not so clear. It's possible due to an accelerated aging of the cardiovascular system, that it's caused by an increase of the atherosclerosis disease, especially related to the inflammation, problems with the valvular function, and coagulation abnormalities. Yes. How we can transform this in specific numbers? Some of the major reports of patients, of ambulatory patients without hospitalization, say that in adult patients, the risk of MACE is approximately 2.2% within 5 years. In a study directed by Dr. Devan Sanghavi from the Mayo Clinic in Jacksonville that we are performing right now, we followed 5,900 patients that were discharged alive from the ICU or from the general floor due to that have an hospitalization due to sepsis, and we observed that in patients without cardiovascular comorbidities, the incidence of myocardial infarction was 3.4%, and the incidence of any kind of stroke was 4%. And this is in patients who don't have cardiovascular comorbidities, but in patients who have the cardiovascular comorbidities previous to the hospitalization due to sepsis, the risk of myocardial infarction was 7.9%, and any kind of stroke 16% after the discharge of sepsis. This is within 5 years of follow-up. This, of course, when we evaluate the cumulative incidence, is much higher. Why? Well, due to this population also have a 38% of mortality without MACE within 5 years after discharge. Therefore, we observed that this population have an increased risk of major cardiovascular events, but we don't know how we can select or recognize which patients will have a higher risk. Therefore, we started to evaluate it with an approach directed with Dr. Dotto Soto from the Mayo Clinic in Jacksonville. We started to think, okay, how we can predict if the patient that we are going to discharge today will have or not a higher risk of major cardiovascular events within 5 years after discharge. Therefore, first of all, we started to using predictive models that right now exist for patients to select preventive treatments. Yes, the most well-known is the atherosclerotic cardiovascular disease predictive model for patients between 40 to 79 years that use demographic data, clinical variables like pressure, blood pressure, and cholesterol, and the medical history of diabetes, smoking, or antihypertensive trait, statin, and aspirin. And this predictive model that's created for ambulatory patients categorize the risk of patients in low, borderline, intermediate, and high risk. And depending on the risk that have the patient, is the treatment that should start for the prevention of these major cardiovascular events. But what happened when we evaluated this predictive model, when we evaluated the predictive performance of this predictive model in septic patients? Well, first, we observed that the area under the ROC curve was near 0.7. That's an acceptable discrimination. But the problem was not the discrimination of the model, was the calibration of the model. Here, in this graph, we can see that these are the observed risk of the observed number of events, and this is the expected or predicted number of events by the model. What this means? This is a group of patients, for example, yes, that have approximately, this group of patients have near 65% of these patients have a major cardiovascular event. But the predictive model, yes, the ASCVD predictive model, predicted for this group of patients only 20% of risk of MACE within 10 years. But we observed a proportion of 65% of events and within 5 years, yes. Therefore, we observed that the conventional predictive models have an under prediction of the real risk that have the septic patient. And this is something that's expected because we know that septic patients will have a higher risk of major cardiovascular events in comparison with patients without sepsis. Therefore, we started to think, okay, we know that the conventional predictive model right now are not so useful. Yes, therefore, we should start thinking in new variables that can predict MACE in sepsis. And in a proposal of Dr. Iván Sangabi and Dr. Ariel Sosa from the Hospital Alemán here in Argentina, we started to evaluate some echocardiographic parameters. Especially, we are thinking that the myocardic strain could be a good predictor of MACE in these populations. And why strain and not the ejection fraction? Well, because the cardiac strain, it's a measure that it's evaluating the the myocardial deformation, yes, and it allows to measure the myocardial shortening, thickening, and lengthening during sepsis. And it provides an assessment of the global heart function, yes. Therefore, we started to evaluate in total 559 septic patients who have the strain measurements and the ejection fraction measurements also, and patients in which we have a follow-up of an average of 3 years of follow-up after discharge, yes. In total, the mean age of these populations discharged by sepsis with a follow-up of 3 years was 63 years. We started with the evaluation of the ejection fraction. Interestingly, we observed that in the crude analysis, patients who have a normal ejection fraction, yes, between 50 to 75, they have a lower risk of major cardiovascular events. That's something that is expected. But what happened after the adjustment by several potential confounder as comorbidities, sepsis, severity biomarkers like SOFA or lactate? We observed that this association disappears with an adjusted odds ratio of 1.03. Why? Well, this is possibly because the left ventricular ejection fraction have a lot of dependency of the load that have the system. If the patient have loading conditions with a higher volume of treatment with a lot of volume, for example, will have different ejection fractions independently of the heart function. And also because it's depending also from the hydroenergy situation. Some patients that maybe have some cardiac problems, if they have a hyperhydroenergic situation with an overload of volume, maybe the ejection fraction will be near acceptable or little reductions, but it's not the reflection of the real severity that have the patient. In this sense, when we evaluate the left ventricular global strain, we observed also an interesting U shape in the relation of the risk of major cardiovascular events within 3 years after discharge from sepsis, yes. But interestingly, in patients who have more higher left ventricular strain, remember that the normal strain is between minus 16 to minus 23, 24. Patients who have values more near zero are worse contractibility. And we observed that in these patients who have a worse contractibility, patients, especially with patients who have left ventricular strain higher than minus 16, this was an independent predictor of major cardiovascular events within an adjusted hazard ratio of 1.38. In this Kaplan-Meier analysis, we divided the population in two groups, yes. First, we performed a restricted cubic spline models to explore what's the best cutoff point to predict MACE. And after that, we transformed this in a dichotomical variable, comparing patients with left ventricular strain higher than minus 16 and lower than minus 16, yes? And in patients who have between minus 16 and 0, we observed here that they have a major proportion of major cardiovascular events within 3 years after discharge, even though adjusting by comorbidities and sepsis severity biomarkers. Well, as a main conclusions, first of all, we know that after sepsis discharge, the patients will have a higher risk of major cardiovascular events. However, the predictive models that we have right now are not the best option. Why? Well, because they possibly will make an under-prediction of the real risk that have the patient. Therefore, it's mandatory to look for new biomarkers of MACE after sepsis discharge. And we think that the echocardiographic parameters will be helpful. However, not the ejection fraction. The ejection fraction, we know it's not only our work, there is other studies that have similar results. That's not a good predictor of MACE. However, we think that the left ventricular global longitudinal strain could be helpful because it's really evaluating the myocardial contractibility capabilities. Finally, we think that the creation of these prediction models, especially for sepsis, could have a possible in the future new clinical implications, because if we can select the number of patients that even though without cardiovascular previous comorbidities previous to the sepsis hospitalization, maybe there is a subgroup that will or should receive some preventive therapies. Well, thanks a lot, Nathan and the team for the opportunity. And now I think that there are the questions, no?
All right. No, great talk, Iván. And certainly I want to circle back to something you said is, right, that our current models, our current projections of the cardiovascular risk with sepsis patients is a gross underestimation of what actually happens, right? So clearly there's an acceleration effect or a secondary risk effect. I can't wait to, I was going to circle back to you later when we talk to Dr. Prescott and ask her if she thinks that echocardiography should be part of the long-term follow-up of post-sepsis patients. That's a concept I've never thought of before. So I suppose my question for you then is, based upon what you're seeing, do you think that echocardiography should be part of that follow-up in our sepsis survivors? Because I'll be honest, I've never thought about that before. But do you think it's, I suppose I'm saying, do you think the data are robust enough that we should really start thinking about screening for accelerated cardiovascular risk with echocardiography?
Well, that's a really good point, Nathan. And one thing that I want to show you is that in the first study that I present, we have 5,000 patients, but in the second study, only 400 patients. Why? Well, this is because the left ventricular strain today is not widely used. Yes, and this is a huge limitation for our study. In this second study, we have some kind of selection bias because the physician make this study for some specific reasons to the patient. This is a retrospective study. However, in the comparison of the ejection fraction, we observed a huge difference. Therefore, in the next steps, we are increasing right now, and we are doing a prospective study of the evaluation of all septic patients with measurements of strain to see if these echocardiographic parameters should starting to be used to predict the capabilities of the models that we are developing right now. But in a second way, we are also creating predictive models without a strain. Why? Well, because we are thinking also in the generalization of our results. If we create a predictive model with these difficult echocardiographic parameters, it's not going to be really extensively used, yes, and especially in lower middle incomes. Therefore, we are working in the two ways. First of all, increasing the number of patients with a strain measurement to see if it's really a really good predictor. And secondly, trying to create a predictive model with more widely used biomarkers that maybe that could be helpful to evaluate if we can use this to evaluate the possibility to start some preventive treatments.
Okay. I apologize to folks putting great questions into the chat. We're a bit squeezed for time. Please save your questions. If we have extra time at the end, I will try as best I can to circle back to you. I promise, but I don't want to shortchange any of our speakers by way of their time. But I do promise I'm keeping track of the questions, and I will try to get back to you when we're done, particularly if we have an open discussion period where all of our experts can weigh in. All right, thank you, Iván. Much appreciated. Now, moving to another continent, staying in the southern hemisphere, but about 16 time zones away, Thomas Rollinson from Australia. And Thomas is, I love it. He is one of our rock star physiotherapists in the critical care world. And his area of interest is exercise and recovery following critical illness, particularly with a focus on muscle wasting in sepsis and the potential of early exercise interventions. I think this is really, really interesting. And clearly we have a true expert to talk about it. So Thomas Rollinson going to speak to us about rehabilitation and sepsis survivors. Thomas, the floor is yours, my friend.
Thanks very much, Nathan. Hello, everyone. Thanks for that wonderful introduction and for the opportunity to speak to you today on rehabilitation in sepsis survivors. So yes, my name's Thomas. I'm an intensive care physiotherapist and also a clinician researcher at the Austin Hospital in Melbourne, Australia. So in my session, we're going to discuss briefly the variable clinical course of sepsis, what we know about long-term outcomes, describe some of the syndromes associated with the survival of sepsis, including post-sepsis syndrome and post-intensive care syndrome and how they potentially overlap, and look at physical rehabilitation in sepsis, including some of the key randomized trials. And finally, an update from the guidelines, recommendations, and any future directions for research that we should be considering. Sepsis, as we all know, is a life-threatening dysregulated response to infection that generally involves systemic inflammation, and it's often been described as an avalanche on the human body. And Niccolo Machiavelli eloquently described in the 16th century that hectic fever or sepsis in the early stages of disease is hard to detect but easy to treat. and in the later stages is easy to detect but difficult to treat. And so today in my talk, looking at long-term outcomes from sepsis and the rehabilitation journey for our patients, we can recognize that some of these problems are indeed difficult to treat, and even 500 years later, we still have much to learn about sepsis survivorship. The clinical course of sepsis can be quite variable between patients. During the initial transition into the septic episode, there's rapid deterioration in general health status, and this often requires hospitalization and potentially intensive care unit admission. And ideally, with our treatment, there's some resolution of the septic episode and some immediate improvements in overall health status, although there is variability in the recovery trajectory and then ultimately in long-term outcomes. Some of these outcomes might be positive, which means that our patients can approach pre-morbid status. They might result in long-term, albeit relatively stable impairments, or unfortunately, these might result in further deterioration, readmission to hospital, and incomplete recovery. And so from a rehabilitation perspective, rehabilitation should commence early, ideally soon after admission to either the intensive care unit or the hospital, and continue across the entire course of recovery. Some recent data from the World Health Organization's global report on sepsis reminds us that sepsis is a common problem, estimated at just under 50 million cases annually worldwide. And mortality remains high at 26% for those admitted to hospital, or 40, or even higher for those requiring intensive care at over 40%. And even in those who survive, mortality over the next year remains high, with 1 in 3 dying within the next year. Noting, of course, that most published data comes from high-income countries. But in terms of morbidity, 1 in 2 survivors won't make a complete recovery in 2 years. 1 in 3 won't return to independent living, and 1 in 6 will have persistent impairments long after their discharge from our care. And the constellation of symptoms that patients experience, that are experienced by survivors of sepsis, has been termed post-sepsis syndrome. And some of the mechanisms behind this syndrome include neuroinflammation in the brain, mitochondrial dysfunction, and these may be exacerbated by any pre-existing comorbidities and frailty syndromes. The symptoms can affect multiple body systems, but common symptoms include depression, fatigue, physical dysfunction, and ultimately these can result in long-term problems that reduce quality of life. And quality of life, health-related quality of life, has been highlighted by survivors in qualitative studies as the most important patient-centered outcome for us to consider. And the risk of post-sepsis syndrome increases not only with severity of sepsis, but it's also higher in those needing intensive care unit admission. And all of this further increases the risk of poor outcomes. Meanwhile, symptoms experienced by survivors of critical illness have been compiled for a long time now under the term post-intensive care syndrome, or PICS. So PICS describes a similar but not identical series of problems to post-sepsis syndrome, which these problems are related to the intensive care unit admission, but don't necessarily reflect just patients with sepsis. So PICS describes and categorizes the mental, cognitive, and physical impairments for survivors of critical illness, and also considers the impact on family members, which has been termed PICS-F. While physical impairments in particular are common, they're also very severe and are long-lasting consequences of survival. With these physical impairments, the muscle wasting, the skeletal muscle wasting that occurs early and rapidly. And this landmark work published in JAMA by Zuden-Pizchiri and colleagues shows that up to 20% of muscle cross-sectional area is lost in the first 10 days. And so this is amongst the fastest muscle wasting rates that have been recorded, and is even more rapid than astronauts in anti-gravity environments. And so this muscle wasting is a result of a net catabolic state, which is comprised of an increase in skeletal muscle protein breakdown and a reduction in protein synthesis. And then this is even further exacerbated by reductions in the ability for the muscle to repair. And so these syndromes often, but don't always, overlap. So as some sepsis patients are admitted to intensive care, they may experience symptoms that might be related to either or both post-intensive care syndrome and post-sepsis syndrome. But for example, physical dysfunction is often present in both. And then more recently, in patients with COVID-19, long COVID syndrome has been described, with similar characteristics also, and these syndromes fit under the more general term of infection-associated chronic conditions. However, given the potential similarities in these problems and similarities in the mechanisms, perhaps we can consider similar therapies to address these problems and learn and extrapolate from the literature that's already available with each of these syndromes. And so from a rehabilitation perspective, just over 10 years ago, structured rehabilitation pathways were proposed in order to reduce the impact of persistent physical impairments post-sepsis. And this is particularly focused at those who are admitted to the ICU. And general principles of rehabilitation would be to start early and focus on exercise training in order to maintain muscle mass, maintain physical function, and cardiorespiratory fitness. So early rehabilitation that starts in the ICU might include progressive mobilization of peripheral limbs, all the way through to functional mobility, sitting on the edge of the bed, standing, transferring, and walking, helping patients get back to their lives. More recently, there's been some novel devices such as recumbent cycle ergometers that have shown promise, allowing the delivery of exercise to patients who are either too sedated or too comatose or too unstable to mobilize. And so these devices may also be used in combination with electrical muscle stimulation, which means that we can stimulate muscles without necessarily requiring the patient to initiate the activity. And whilst there isn't a huge volume of randomized controlled data, the first prospective randomized controlled trial of early physical rehabilitation was conducted about 10 years ago. This was a small study, looked at 50 adults with sepsis. They were mechanically ventilated in the ICU, and they were randomized to receive an intervention of 30 minutes daily of individual multimodal rehabilitation compared to usual care. And the primary outcomes included physical function, health-related quality of life, with secondary outcomes including muscle strength, physical function, and inflammatory cytokines. And so for patients in the intervention group, they reported improvements in physical function and also physical role domains of the SF36. But interestingly, there were also some signals of reduction in the pro-inflammatory cytokines of interleukin-6 and increase in the anti-inflammatory cytokines of interleukin-10. This was followed up by a small pilot study of electrical muscle stimulation. And in this study, they looked at randomizing 25 adults to 30 minutes daily of upper and lower limb stimulations up to 5 days per week. And they aimed to assess muscle power using handheld dynamometry and mechanical ventilation duration. And so they found the electrical muscle stimulation was safe and feasible. And from Kaplan-Meier analysis, you can see there was no difference in mechanical ventilation duration. And unfortunately, due to some issues with patient cooperation, they were unable to complete adequate strength outcome assessments. The more recent international multi-center trial, which is the ESTIM cycle trial, which I was involved in, more recently looked at 162 adults who are mechanically ventilated with sepsis, and that randomized patients to 60 minutes, 5 days per week of combined recumbent cycling with functional electrical stimulation compared to usual care, and the primary outcome being quadriceps strength at hospital discharge. And whilst there was no difference in the primary outcome with the addition of FES cycling, it should be noted in this particular study that the usual care arm received a relatively high dose of usual care rehabilitation daily. And it's also possible to consider that the intervention itself was inadequate to overcome the muscle injury due to potentially the anabolic resistance that we see in sepsis. So there remains a strong rationale to provide rehabilitation programs for survivors of sepsis due to the potential for improvements in physical quality of life and to help patients return to their lives that they would enjoy. Although it should be noted that there remain limited specific studies of rehabilitation in sepsis, and so right now the certainty of evidence is low. But the surviving sepsis guidelines from 2021 have included a best practice statement that survivors should be assessed for physical, cognitive, and emotional problems and suggest referral to follow-up if available, and continue to suggest rehabilitation programs for this cohort. So in summary, sepsis survivors continue to face persistent long-term physical challenges that impair quality of life. Survival is just the beginning, as Nathan said at the start of the session. So to optimize recovery, structured and individualized rehabilitation should commence in the ICU with a focus on early mobilization. but there's still a need to further explore the mechanisms of muscle wasting, particularly in sepsis, if we are to improve the effectiveness of rehabilitation. And finally, further research is also needed to understand even longer term outcomes greater than 1 year post-discharge, and focus on those who live in low and middle income countries. Thanks very much for your attention, and look forward to the questions.
Thomas, thank you. I think so important to realize that, right? We too often say, oh my God, we can't do PT and these patients are too sick. In fact, that might actually be the exact population that needs it the most, right? So I think we need to fight some of our own instincts sometimes in order to kind of push people a little bit. A really interesting question here from the Netherlands, actually, probably related to the likelihood or the feasibility of post-ICU rehab is, what about post-exertional malaise? Right, we've certainly kind of this has come to the forefront in the long COVID cohort, but right, the people that just can't really even generate the energy to participate in physical rehabilitation. How do you work with that particular challenge?
Yeah, I think I agree. That's a very interesting and challenging question, particularly for clinicians who work with patients with these kinds of syndromes. And certainly, I think we're starting to realize the impacts of things like post-exertional malaise. And I think that the using a multidisciplinary approach, using clinicians who are familiar with the kinds of problems that survivors can deal with, means that the interventions can be tailored and individualized to that patient. Some explanation of understanding of those symptoms and the importance of, even if the intervention is gentle, anything is better than nothing. So I think the most important thing for clinicians in that space is to listen to their patients, to be aware of their symptoms, and to come up with a patient goal-centered approach to be able to prescribe the rehabilitation intervention and consider things like fatigue as well. So it's certainly a challenge, and it may limit the amount of activity that patients can participate in, but it's still very important to be able to continue some level of activity and rehabilitation well after discharge.
I think, so to me, that really speaks to the fact that even in rehabilitation, it's not a one-size-fits-all approach, right? That it really does need to be tailored for the individual in terms of what their goals are, what their tolerances are. Right, so just saying like, oh, right, post-sepsis needs rehab, send to PT. It's right. The recovery process, I think, is going to be a lot more nuanced and a lot more individualized than I think we even appreciate.
Yeah, I think that's exactly right, and even more importantly, to consider in a research sense as well, when we're considering about dose of intervention and how much rehabilitate. If we, it's not exactly like a drug where you can guarantee the patient will receive an exact dose of the intervention, because, as you say, the rehabilitation intervention is often tailored to that individual. So I think we have to consider it in clinical practice, but we also have to consider it from a research sense as well. Is how do we measure the amount of intervention that our patients are receiving, and what impact that may have on outcomes.
So interesting. Okay, we could talk for hours.
You could indeed.
Alas, we must move on. Well, fortunately, we have wonderful speakers yet to come, but yes. So moving on now, crossing over to the Northern Hemisphere, to that powerhouse, university in a small German town of Jena, Dr. Carolin Fleischmann-Struzek, hope I'm getting that close to correct. A name I think clearly well known to many of us in the sepsis world because of her stellar work on the global burden of disease study, which really pointed out just how prevalent and how devastating the impact of sepsis is on the global health. So, Carolin, of course, thank you for that great work. Carolin is a physician and scientist at, I mentioned, the Jena University Hospital, that tiny town with a major medical center in the sepsis world. And her current research focuses really on the epidemiology, long-term consequences of sepsis and related severe infections. And I love this, and you have to explain this to me, leading a study on the sepsis patient journey. I love it. I can't wait to hear more. So, moving on, then Dr. Carolin Fleischmann-Struzek, going to speak to us about long-term morbidity and functional dependence after sepsis. Professor Struzek, the floor is yours.
Nathan, thank you very much for this very kind introduction. Well, this is the last session of this really great World Sepsis Congress, and we already have heard a lot about the challenges survivors and their relatives face after sepsis, sometimes even years after the acute disease. And these impairments include new physical, mental or cognitive disorders, often summarized as post-sepsis syndrome. However, our understanding of the pathophysiology and also the epidemiology is still incomplete, as large cohort studies on sepsis survivors that include particularly sepsis survivors, not general ICU survivor populations, are still scarce. And that's why we started the Mid-German Sepsis Cohort in 2016, which is a multi-center cohort study including patients of 5 German ICUs, aiming to assess the functional dependence, morbidity, and mortality until 5 years after sepsis. And the important part was that patients on the participating ICUs were screened daily for the occurrence of sepsis, and patients that were identified with sepsis were invited to participate in the cohort, so that we had a really complete baseline sample of patients. And in the following minutes, I would like to present you the results of the 3-year follow-up, which included, out of the sample of 3,200 ICU patients identified, around 700 patients in the follow-up cohort. And at 3 years, after sepsis, we were able to still interview 330 patients. And I think the main finding was that nearly all of these patients had subjective impairments that occurred after sepsis and still were present at that time. Mostly at the physical domain, nearly all patients were affected by physical impairments, but also cognitive and psychological impairments were quite common and also often overlapped. In terms of common symptoms, most patients reported cognitive symptoms, but also often psychological symptoms, respiratory symptoms, walking difficulties. So it was a really broad spectrum of impairments which affected the survivors in our cohort. And interestingly, over time, we didn't really see a decline in impairments. Psychological and physical impairments nearly remained stable in prevalence, while cognitive impairments increased, likely as patients were older, as the follow-up time grew. All these impairments, of course, had impact on a functional capacity of patients. We assessed limitations in the activities of daily living and the need for chronic care, either by formal care services or informal caregivers. And we found that around 20% of patients remained in a state of functional dependence after ICU discharge, while around 1/3 approximately regained functional independence. And there was also a really high long-term mortality. The risk of dying within 3 years after sepsis was around 50%. Of course, it's important also to investigate which patients were at particular risk for a reduction in their ability to perform the activities of daily living. And similar to findings from other studies, we found that patients with an advanced age, patients with pre-existing limitations in their activities of daily living, and patients with cerebrovascular diseases were at particular risk. for impairments at 3 years. And interestingly, at that time point, the severity of the acute disease was not associated with long-term impairment. These impairments, and I would like to add some finding from other studies we did in our group using nationwide health claims data. These impairments led to a high proportion of patients being rehospitalized within 12 months after sepsis. Nearly two-thirds of patients were affected. Rehabilitation due to infection due to sepsis were common. And also only 3 out of 4 sepsis survivors returned to work after 12 months. Survivors without return to work were particularly affected by impairments. And another result, and that is something I would like to highlight of the sepsis project was that we found that the broad spectrum of long-term impairments not only affected patients after the most severe manifestations of sepsis, but also after sepsis without organ dysfunction, after sepsis treated outside the ICU. And that is something you might know from COVID-19, where also patients after really uncomplicated courses of the infection were affected by long-term impairments. And that brings me to the overlap between COVID-19 and post-sepsis. The long-term impairments I showed you from our mid-German sepsis cohort, they were quite similar to what we observed in patients after COVID-19. And they are also really similar to impairments that we observe in other ICU survivor populations. So that means from a conceptual point of view, we understand the post-sepsis syndrome as an entity with overlaps to other post-infectious syndromes, with overlaps to post-intensive care syndrome, which is part maybe of a larger entity of infection-associated chronic conditions. And I think that is something we need to focus on in the future, because we can leverage the similarities of these syndromes to improve the patient care after these life-threatening or infectious diseases. So to sum up, long-term impairments after severe sepsis are more frequent and more diverse than previously known. They can affect all sepsis patients and are not just limited to ICU patients. They can lead really to a lasting loss of independence with really severe consequences for the everyday life of patients, which, and that was also previously in the talk discussed, this underlines the need for rehabilitation aftercare, which is today really scarce. There are no sepsis-specific concepts, but that's something we need to improve the care of the survivors. Yeah, and with this, I want to close and thank you very much for the attention.
Thank you, Carolin. Great talk. Clearly, some eye-opening results, yet shocking in some ways. I suppose I do have a question. You rightly point out that there are long-term effects, debilitation, professional, physical, psychological, what have you, in all comers, not just ICU sepsis, right? All types of infection at every level. And clearly there's a group that stands to benefit, but in the setting of limited resources, right? Because not every hospitalized patient with an infection can access, long-term surveillance, long-term care, right, for 3 years afterwards. How do we best identify those patients that are really either at highest risk of those complications or most likely to benefit from those interventions?
Well, I think to identify patients at risk, I think it needs more research in also in non-ICU populations, because they are also under risk. So we need research to understand the pathomechanisms to identify risk groups. But on the other hand, I think it needs a really low-level screening policy for survivors so that we can identify those survivors with impairments closely after discharge, and support these survivors with adequate therapies and aftercare. And I think course capacities are limited, but if we include and engage, for example, general practitioners in that aftercare, we could offer a broad screening and then offer therapies which are really targeted and interdisciplinary for survivors that show symptoms or impairments after sepsis. So I think it really needed a stepwise approach to better meet the needs of these patients.
Excellent. Okay, again, that's a quick question. Sorry, Dr. Prescott. We're going to hold up just a little bit longer. A really interesting question from Japan, asking whether or not you've seen, in Germany at least, a difference in sex, male, female, in terms of long-term morbidity and function following sepsis. Right?
Yeah,
or is it more likely to be seen in men, in women?
Well, we investigated that in another study, and we found really large differences between male and female patients, with psychological and physical impairments being more common in women, but mortality and cognitive impairment being more common in male. So that is something I think which also have important implications, but is also driven by, I think, not only like biological reasons, but also by healthcare utilization pattern, as we used diagnosis data from health claims to identify these long-term impairments.
Wow, that's really interesting. I did not expect that.
Yeah.
You learn something new every day, or many new things every day. Well, our next speaker needs very little introduction to the sepsis community. I think it's fair to say that Dr. Prescott is fairly well established in the sepsis world. Dr. Prescott joins us from the University of Michigan, and truly is one of the global experts, without exaggeration, in long-term outcomes and recovery after sepsis, and certainly serves as co-chair of the Surviving Sepsis Campaign guidelines. Dr. Prescott, if you need more people to help, I volunteer. No, seriously, thank you for sharing your time and expertise. I can't wait to hear this talk. And Dr. Prescott is going to be enlightening all of us on the hospital care at home model for patients with sepsis. Can't wait to hear it. So Dr. Prescott, the microphone is yours.
I'm muted. Excellent. Well, thanks so much for the introduction. It's really always a pleasure to be speaking in this really excellent meeting. I'm going to be talking about a little bit different topic than maybe I normally talk about. This is hospital care at home, a model for patients with sepsis. I have no financial conflicts of interest. Background for this talk. So sepsis, as you know, is generally considered as a condition that requires hospitalization. And indeed, in the US, our surveillance definition actually bakes this into the definition. They say that this requires 4 days of inpatient antibiotics in the CDC adult sepsis event. But sepsis 3, our most recent clinical definition, says sepsis can be identified as 2 or more new SOFA points due to infection. And so, that may happen in patients outside the hospital. And so it kind of raises this question: to what extent are patients meeting these criteria managed outside the hospital? And this question was actually identified as one of the key unanswered answered questions about sepsis epidemiology in the 2020 WHO Global Report on Epidemiology and Burden of Sepsis. And so I kind of got interested in understanding what do we know about this topic. So there's really very little that's been published on this. This is a study that is from 2017 that looked at this data set called the National Hospital Ambulatory Medical Care Survey. This is essentially a random sample of 500 emergency departments in the US, and these sampled emergency departments submit their data for all of the people that they see over a 4-week period. So the investigators used this data set to identify patients with infection, and that was based on essentially abnormal temperature and the vital sign data, an infection diagnosis, as well as other evidence of acute organ dysfunction from the sort of data variables available in this data set. And then they asked how many of these people get discharged home. And what they found was that about 20% of patients identified as meeting these clinical criteria consistent with sepsis 3 are discharged home. They did some sensitivity analysis using slightly different definitions and really found that kind of like, regardless of how they operationalize this, about 20% of patients was discharged home. So that was interesting. The next study that was published on this topic that I'm aware of is a study by Iván Pelton and colleagues out of the Intermountain Healthcare System in Utah. This was published in JAMA Network Open in 2022. And they used electronic health record data from 4 Utah emergency departments. And in total, they had about 12,300 patients treated by 89 different physicians that were included in this study. And these were all patients who had evidence of infection during their emergency department stay based on cultures being collected, antimicrobials being given or prescribed in the emergency department, and clinical documentation of infection or suspected infection, and that they had 2 or more new SOFA points based on their electronic health record data. I will say, like, the one caveat was they did not have great complete data in terms of baseline organ function in most patients. So what did they find? They found that 16% of patients meeting these sepsis criteria in emergency department were discharged home. And these patients who were discharged home as opposed to being hospitalized tended to be younger, average age being 54, where it's typically around, upper 60s or 70 for a US like inpatient sepsis hospitalization cohort. Disproportionately female at 66% of those discharged home, and disproportionately urinary infections. 12% of these people, however, had arrived by ambulance. Their mean SOFA score was 2.6, but it appeared to be safe. Only 1% of these patients discharged home had 30-day mortality. They also wondered, whether these patients getting discharged home, if this was a reflection of like there was just no room to admit these patients into the hospital. And so they looked to see whether there was differences by whether it was a weekday or a weekend, and what the ED occupancy is, and actually found that there was not any difference. Interestingly, though, they then looked at the variation across these physicians. So in total, there was 89 different emergency department physicians that worked in these 4 hospitals that were part of this study. And they found quite large variation across the physicians, ranging from none of these patients being discharged home to 39% being discharged home in the unadjusted data. And then when they adjusted for differences in kind of patient characteristics and illness severity, they still found fairly wide variation at 8 to 40% discharged home. So about 4-fold variation across physicians. All right, so pivoting a little bit now, I'm going to talk about this other model of sort of taking care of people at home besides just sort of treating and releasing them from the emergency department. And that is this model of care called hospital care at home, which is this idea about trying to provide hospital level services to patient, but doing it at their own home as opposed to in a physical brick and mortar hospital. And so this concept really sort of developed around 2020, and I think accelerated over the course of the pandemic when hospitals were quite full and we're trying to think of creative solutions to sort of expand their capacity. And so this study I'll share here, this was published in Annals of Internal Medicine in 2020. This was a randomized clinical trial of the hospital care at home model. And the setting for this study was 2 emergency departments in Boston affiliated with the Harvard Medical Center or Harvard Medical School. And they in the study population, they had 91 patients who were in the emergency department who were deemed to require hospital admission. And so when they were sort of called up to be admitted into the hospital, that's when this clinical team would then come and say, oh, you meet eligibility for our study, like, would you like to be randomized to being admitted, versus going home with this hospital care at home model. And so in terms of the actual intervention being delivered, so this hospital care at home model, the patients would go home and they would be visited by a physician once daily. They'd be visited by a nurse at their home twice daily. And there was this opportunity for additional visits if deemed clinically necessary. And they had remote monitoring via a skin patch that collected vital signs like telemetry, activity levels, and they used a machine learning algorithm based on this data that they were collecting from this wearable patch. And so they were sort of monitoring these patients for clinical deterioration, and they would use that to sort of check in on the patient more frequently. They used video, telephone, text messages to communicate between the patient and the care team. And there was select stuff they were able to do in the home, like point of care blood testing, laboratory testing, and select radiology procedures like ultrasound. And I believe they could do maybe x-rays. Don't quote me on that one. I'm not 100% sure. And then they could do video consultations if they wanted sort of like a subspecialty, consultation with cardiology or something like that. In terms of inclusions and exclusions, so they had a list of specific diagnoses that they considered for inclusion that included, infection and, of course, included sepsis. Exclusions were things that all made good rational sense, like if you didn't have a safe house to go home to, if you had acute delirium, if you were unable to get IV access for the patient, they would not be eligible for the study. So patients were randomized, and this here shows the results of the patients who were randomized to go home for this hospital care at home versus admitted to the brick and mortar hospital. In total, patients who went home were followed for their hospitalization for 4.5 days versus 3.8 days in the physical brick and mortar hospital. So it's sort of a slightly longer encounter duration, but a much lower intensity of kind of the medical interventions being done to you. So on average, 3 blood draws versus 15. 14% got imaging at home versus 44% in the hospital, again, after they got admitted from the emergency department. I think most people had some sort of imaging in the emergency department. The rate of consultation was 2 versus 31. And then super, sort of compelling, patients who went home spent only 32% of their day lying down compared to 66% of the time when you're in the hospital. So patients are largely just laying in bed. And then when they looked at outcomes, they found that the rate of 30-day readmission among patients who went to this hospital care at home program, rate of readmission was only 7%, so dramatically lower than the 23% readmission among people treated in this traditional brick and mortar hospital. Cost of this hospital care at home was less. And when you looked at the cost out to the full 30 days following admission, including these kind of subsequent readmissions, there was a 29% lower costs on healthcare spent on the patients who got the hospital care at home. They did interviews with the patients, family members of the patients, and clinicians that were involved in this intervention to understand sort of how this was experienced. And one of the key themes that emerged from this is that there's a lot of factors in the hospital care at home model that promote healing. So when patients were at home, they had better sleep, they had more physical activity, they had improved social support from their family, the environment was familiar to them, it was calmer, they had this locus of control. So there was really all of these benefits that the patients experienced, which make good intuitive sense. There was kind of mixed results about safety. On the one hand, some people said, oh, well, I was pleased because I sort of perceived that I had a lower risk of getting a secondary nosocomial or hospital-acquired infection. And on the other side, some people thought, well, if I got really sick, this might have been scary because, they couldn't have instantaneously responded to me, although they did have this ability to kind of message with or call the care team at any time. So a little bit of a mixed result about the feeling of safety and a recognition that this model is not for every single patient. And if you're too sick, then this would not work. So overall, there was kind of trade-offs, certainly with hospital care at home that, you cannot do as intensive monitoring. There's this potential for delays in identifying or responding to clinical deterioration, but a lot of benefits in terms of fewer risk of iatrogenic complications, this familiar environment, better sleep, family present, more active. This is a follow-up study by the same author group that has described kind of the national U.S. experience with hospital care at home as of 2024. There's now 300 hospitals, or 5% of all hospitals in the U.S. that have the capability to provide hospital care at home. There have been about 5,000 Medicare patients who have had these types of hospitalizations paid for under our federal Medicare program. And the most common diagnoses include sepsis, UTI, and cellulitis. So overwhelmingly, it seems to be something that is used for acute infection. The escalation rate of admitting patients back into the hospital nationally is 6%. 30-day readmission is 15%. 30-day mortality rate is 3%. So not as good as that initial clinical trial that kind of really demonstrated the benefit of this type of program, but still better than what is seen in traditional brick and mortar hospitalizations. University of Michigan, where I work, does have a program like this. We've treated over 400 patients at this point with this program, and about 13% of the patients that we have been for a diagnosis of sepsis. Most commonly, patients get transferred to hospital care at home after about 12 to 24 hours, either in our emergency department and or in our hospital wards. To date, we've only had 2 escalations back into the hospital and 1 death at home during hospital care at home treatment. And there has been overwhelmingly very high patient satisfaction. So in sum, I think there is evidence that certainly some subset of our patients can be rapidly transitioned to home-based care after initial diagnosis, initial sort of recognition and stabilization from sepsis. This appears to be a safe and preferable option for select patients that might jumpstart this recovery process. I think certainly, it takes a lot of resources to build a program like this. And so the message here isn't like everybody needs to go home and immediately build these things, but I think it's sort of compelling to think about, like, what are things that we can do in our brick and mortar hospital that get some of those benefits that we see in the hospital care at home? How can we make the hospital more comfortable and more promoting of recovery so that we can maybe get some of these benefits that we clearly saw in this study? So I will close there, and thank you, and happy to take questions.
Thanks, Hallie. Really kind of interesting, almost countercultural approach to kind of the sepsis world, right? I think for me it's enlightening that I guess the concept that one can manage sepsis outside of a hospital. Right? I think we've been so hardwired to like, oh, sepsis means really sick equals hospital.
Correct.
But to say that maybe there's a group that would do even better if they were allowed to just stay in their home environment to be managed there.
Like, I really think about it as this trade-off, right? There's a lot we can do in the hospital, but you're giving up a lot too. You're giving up your home bed, your home environment, your pets, like you're giving up a lot of the sort of comforts that you have at home. And again, this like mobility, right? Like there was just dramatic differences in the mobility of the patients who did hospital care at home versus the brick and mortar hospital. And so I think you always have to think of any intervention as having pros and cons. Like there's no free lunch, and that includes a hospitalization.
Absolutely. I did want to come back just because I promised one of our participants that I would ask you this question. And I think you're the right person to ask. When looking at data on the post-sepsis syndromes, whatever you want to call them, is there a core outcome set that investigators in this field routinely use in order to ask these questions?
Yeah, that's a great question. I think, I think there's probably a variety of different core outcome sets, because I know that there's been ones made for sort of COVID and post-intensive care and sort of post-respiratory failure. And so I would say there's probably more than a single one. But I think there's sort of this recognition that survival and mortality generally is at the sort of very top of everyone's list. And then beyond that, it's things about sort of function and cognition, and then also kind of ability to return to your kind of like normal activities and sort of normal, roles. Yeah.
Okay. One last quick question from Saudi Arabia. Wow. Okay. We're all over the place today. Given the promising results of this hospital care, how do you envision the integration into mainstream healthcare systems in the future?
Yeah, I mean, I think this still is, pretty small. I mean, as a very small amount. Like, so I run this statewide sepsis registry for Michigan, and so we are trying to capture like how many patients, leave or are treated under this model, and it's like a tiny little tip of the iceberg. But I think there's interest in it for a variety of reasons. As I showed, like once you get this program launched, which is hard to do, it can be cost saving. And secondly, it is overwhelmingly liked by patients. Again, not for everyone. And so like when it's implemented here at University of Michigan, we don't tell you like, oh, you got assigned to hospital care at home. Like we're going to teach you at home. No, it is offered as an option, and patients either opt in or say, yeah, that doesn't sound like for me. Right. So there's like this screening process. Are they clinically appropriate? Do they have an appropriate home setting? Do they live within a distance that we're going to be able to provide these services? And do they want it? And if all of those things are true, then this can be a really good option. I think the other thing is that, as long as insurers continue to cover these types of hospitalizations, like a normal hospitalization, like the market kind of responds and helps to create resources. So as I understand it, there are a variety of companies that provide a bunch of the services. So they like provide the laboratory services and the monitoring services. And so like then the medical centers will provide like the doctors and the consultations. And so that's another way that can make it easier to build these things, is that you sort of, you work with another company that provides some portion of the services, and then they can have an economy of scale because, they're providing lab work for like this geographic region, even though there may be multiple different hospitalizations, and it sort of, that can work out too. So I think like, as long as insurers will cover this, as long as patients like it, as long as it continues to make sense, I think there are sort of creative ways to make it feasible. Because like I kind of heard you laugh, like you look at this and you're like, that's impossible. How would you ever build this thing? But like, companies crop up if they see an opportunity and there's sort of a compelling use case here. But again, I think the other big lesson from this is just like, how do you make the actual real hospital, like better for, sleep and mobility and comfort and all those kind of things, I think is another really important lesson from this type of work as well.
Yeah, absolutely true. Oh, alas, could discuss it at length. And I'm sorry to our participants, I can't get all the questions because I have a ticking clock in front of me. We have to move on. So Dr. Prescott, thank you so much for proposing an alternative model, I think, to what a lot of us think sepsis care is. So thanks for kind of broadening the paradigm a little bit. Staying within the state of Michigan, we have Dr. Stephanie Taylor joining us, professor of medicine, also at the University of Michigan, with an active research portfolio on developing health system interventions to improve outcomes for hospitalized patients, particularly in the area of sepsis and the optimization of recovery for survivors. Clearly an important and kind of useful follow-on to Dr. Prescott's talk. So Dr. Taylor's talk will be entitled The Impact of Post-Discharge, Sepsis Management on Mortality and Morbidity. So without further ado, Dr. Taylor, please enlighten us.
Thank you. I am honored to be here, as Dr. Prescott also said, just such a pleasure to be at this particular meeting and to follow up my brilliant colleagues. I'm going to talk about post-discharge sepsis management, kind of as a complement to what other folks said. So Thomas spoke about rehabilitation, others spoke about some outcomes. I'm going to focus kind of on follow-up and health system approaches to caring for patients after sepsis. I have no financial disclosures to report. Just to piggyback on what other folks said, just the key of this session, I think, is that surviving sepsis, just making it out of the hospital, is not the end of the war. It's one battle, but there's still quite a war to wage after patients are discharged, and patients face so many challenges after discharge that had, I think, decades ago been quite neglected, and now we're beginning to identify those and develop ways to approach them. On top of all the symptoms that Carolin and others really talked about, really practically speaking, sepsis survivors experience quite a high rate of hospital readmission. So lots of different studies kind of center around the idea that sepsis patients, 1 in 3 who survive sepsis, will be readmitted to the hospital within 90 days, which is a pretty striking number. It's also a very expensive condition for patients readmitted to the hospital. In addition to being admitted quite frequently, patients with sepsis have a long-term increased risk of mortality. Up to 1 in 5 older patients experienced late mortality, and about half of that was attributable or thought to be attributable to the sepsis event itself, not necessarily kind of baggage that people brought into the sepsis illness, but the event itself triggered something that it led to increased risk of mortality that persisted up to a couple of years later. So that gets us to how do we improve those outcomes? And I like this slide because we tend to focus on practices that happen after discharge, but it's really important to remember that long-term outcomes are also influenced by a lot of the early stuff that we do, and getting antibiotics right and getting that early treatment right has long-term effects and improves long-term outcomes too. So we can't kind of lose sight on our momentum in making progress there. And then other things that we can do in the hospital, like Dr. Prescott and I didn't practice our talk, but the things that she was saying about making the hospital a better place to recover also represented here, really not waiting to start recovery until the patient gets discharged, but creating a hospital environment that's focused towards recovery as well. But a lot of my work and work that I'm going to share here is going to talk about after discharge. What can we do to improve or affect patients' morbidity and mortality? I also put this in here because it's really important when we think about how do we reach out to and care for patients after discharge. At least in the US, quite a few patients don't go home after discharge, even with home health or other home services. If you combine a skilled nursing facility and long-term acute care hospital, over a quarter of patients actually end up going to some sort of facility after discharge and aren't discharged home. And that presents a really unique situation of how do PCPs care for patients in that setting, or how do transition programs care for patients in those settings, which are traditionally kind of hard to reach and hard to engage with patients while they're in those type of settings. So that's a unique, I think, cohort of patients that deserve special attention. And obviously patients who are discharged to those settings have even higher rates of, disproportionately higher rates of readmission and mortality and other adverse outcomes. So on to what can we do for patients after discharge. In this kind of right panel, I summarized recommendations from Dr. Prescott and Derek Angus wrote this really great review article, kind of expert guidance on what we should do for patients after discharge for sepsis. And it kind of boiled down to about 4 practices that can be summarized as screening for common treatable impairments after sepsis, reviewing and adjusting medications, anticipating and mitigating risk for common and preventable causes of health deterioration, and understanding and establishing and documenting patients' goals of care. And some of our early work in this area, we went through and did chart reviews of about 200 patients. And if I asked kind of any general hospitalist or PCP, are you doing these things for your patients after sepsis? You'd say, of course, those are common sense things. Of course, we're doing those for our patients. But in our review, we found that these things were actually pretty uncommonly done. And it was particularly uncommon to have all of them done. So only about 11% of patients had all 4 of these very common sense things, and fewer patients had each of these components. But what we did find was that these things actually work. And when you associate whether or not these care activities occurred with the odds of readmission and mortality, the more of these things you get, the lower your risk of readmission or mortality. So common sense things, but we're not doing them. And when you do them, they're associated in a dose-dependent way with reduced readmission and mortality. So we really thought that there has to be ways to kind of operationalize these things. It's an implementation problem. How do we get these things done in practice? And I think other groups have been working on that too. One way of doing that is sort of in that getting a better follow-up with your PCP or with something like home health nursing. And Dr. Bull's group at Penn has done a really great job really investigating this. And I find this particular project really interesting. So these were patients with, I think it was called severe sepsis at the time of the study, who were discharged and had home health care. And they looked at the patients who either got kind of a quick visit from a home health nurse or a delayed visit, and a quick follow-up with their primary care physician, or a delayed visit. And you really had to have both. Either one wasn't associated with a reduced risk of readmission, but if you got both a quick nursing visit within a few days and a follow-up with your doctor within a week, that was protective against readmission. Unfortunately, only 28% of patients with this high-risk sepsis discharge actually were able to get both of those pieces of follow-up. And this group is doing some really interesting work and trying to identify obviously, home health and primary cares are scarce resources, and so they're helping identify which patients preferentially benefit from this quick follow-up so that they can prioritize that and see if that improves some of the delivery of this care. Another interesting finding from this group that looked at patients discharged after sepsis who had home health care versus not, they actually found that patients who received home health care had a 14% higher odds of 30-day readmission, which is a little bit counterintuitive, I think, to their hypothesis, but I think it introduces an interesting idea that readmissions in populations that are this sick may not be bad. And we're really trained to think about readmissions as a failure, as a bad outcome. But in this case, where patients are super sick and they're being discharged quite vulnerable and have high mortality rates that are persistent, perhaps the job of the home health nurse or the job of the early PCP follow-up is to identify needs and escalate that appropriately to a hospitalization. And so I think this addresses some really interesting things for further research in terms of what are the activities that are important to be doing for these early visits. The next group of post-discharge work I want to share is Dr. McPeak's work in Scotland. Her group does so much great work in this area, but I'm going to talk about her INSPIRE program. INSPIRE stands for Intensive Care Syndrome Promoting. It's a combined medical and social program that's delivered to patients and their caregivers, really focused on this idea of whole health. And addressing all of the multi-level needs that patients have after discharge from sepsis. And they put together this really, really awesome program. They did a study comparing patients who received this program to a group of non-randomized controls across 9 hospitals in Scotland. And really encouraging results here. So patients who received the program had a better health quality of life score, better self-efficacy, lower rates of depression, lower rates of anxiety, lower rates of pain across multiple ways of measuring that. And so this integrated health and social program that met patients' health needs, but also really looked at their social needs, seems to be promising in this area. And then the last thing I'll talk about is what our group did initially at Atrium Health in North Carolina. We built a nurse navigator program to help patients with sepsis transition out of the hospital and with a focus on recovery. And so this program used nurse navigators who are trained in case management, care management, and also their RNs. Several of them were intensive care nurses who participated in this program. So they identified patients while they were in the hospital with sepsis, followed along their clinical course through the electronic health record, so they had a really good sense of what had happened to the patient in the hospital. Near the time of discharge, they made contact with the patient, introduced themselves, developed that relationship, did some health literacy assessments. The turning point, I think, is in this early contact. So within 48 hours, the nurse navigators reach out to patients, do a review of their medications, reassess their symptoms, assess for vital sign instability or anything that might need immediate escalation, and provide support to them. And then our nurse navigators continue to touch base with patients every few days for the first month, and then less regularly or as needed through the next 90 days. And they continue to address a variety of needs that patients had, escalating that to their primary care provider or to other resources as needed. And in this program, our initial evaluation of the program, we evaluated the effect of patients we randomized patients to receive the STAR program or usual care, and we evaluated the effect on a combination of readmission and mortality at 30 days. And so in the initial clinical trial, we found about a 5% reduction in readmission and mortality for patients who had support through the STAR program versus patients who had the usual care. We did a longer follow-up, so that was at 30 days. At 12 months, that difference was sustained, and patients who received support through the STAR program had about a 7% reduction in readmission and mortality compared to patients who received usual care. And I'll point out that even though we were so excited that this program had benefit, when you look at the absolute numbers, and this lines up with some of Carolin's reports and things, the percentage of patients who were either readmitted to the hospital or died at a month was 65% even in the intervention group. So these are still patients who have really high adverse outcomes, even in kind of an optimized intervention group. And then people ask me a lot, what exactly did the intervention do? What did the STAR navigators do? And so we went through and did sort of almost a qualitative analysis of all of their notes and really drew out the different components of care that they were doing and the frequency with which those components were being delivered. And as you can see, that these navigators are really just incredible unicorns that can do almost anything and really provided a tailored set of care to patients depending on what they needed. So the most common thing that they did was care coordination. So they would help patients arrange follow-up or reschedule visits if they needed to, or those type of things. There was a lot of health promotion counseling, so lifestyle, exercise, smoking cessation, reminders to take their medicines or encouragement to take their medicine. Emotional listening, which is not something that we necessarily designed to be part of the program, but I think aligns with some of Joe McPeak's work, that a lot of the role of these navigators was just being present and validating what survivors were experiencing or caregivers were experiencing and providing that kind of anticipatory guidance for patients and caregivers. Symptom management was quite common, medication management, chronic disease management. Again, patients with sepsis rarely are healthy when they get sepsis. There's often CHF or COPD or other things in the background that can escalate quite easily while the sepsis is being treated or they're recovering. So addressing social determinants of health, as you can imagine, was an important part of this work. They played a big role in care setting, advice, and guidance. So a lot of the quotes that we have would be, the patient would ask the navigator, "I have a headache. Should I go to the emergency room?" And the navigator would be like, "No, definitely not. That's not the place for you to be. Take some Tylenol and it'll be fine." Or the opposite. The patient would be like, "I feel really dizzy and confused. What should I do?" And the navigator would be like, "That's bad. You need to go to the emergency room." And so providing that kind of informed guidance about when and where to seek care. And they also had a role in providing some primary palliative care, which is really important in this group. So again, when people ask me, what is the secret sauce for why this worked, it's hard to say. It's really kind of this pluripotent, such a heterogeneous group of needs in sepsis survivors. And I think all of the people that spoke before me mentioned that. And so the beauty, I think, this intervention was its ability to kind of tailor to what everyone needed. So in summary, sepsis survivors have high morbidity and long-term mortality after discharge, as others have pointed out. Different care models that take a multi-level approach to addressing the challenges faced by sepsis survivors show promise. We just have a lot of work to do to understand how to operationalize these and how to implement these in ways that help the most people possible. That's all I have.
Oh, plenty to chew on for sure. Unfortunately, Stephanie, I don't think we have time for questions. I have failed in my moderating duties. We are a good 10 plus minutes behind, but I'll try and circle back to kind of an open discussion period if that's okay. Okay, so all right, our final speaker, as promised, is Professor Choong, joining us from our neighbors to the north, up in Canada, and going to be talking about, I think, a population that we often forget about in kind of the bigger sepsis dialogue, and that's children and what effects it has on our pediatric sepsis survivors. Without any further ado, Dr. Choong, please tell us about the children.
Thank you very much, Nathan, and it's really my privilege to be presenting at the very end, last but not least, the children. What about the children? And it was really a pleasure for me to listen to all the talks that have gone on before and actually try to summarize the pediatric perspective in 10 minutes. The first is the burden of sepsis in children. I think while mortality in children with sepsis has decreased over the last 50 years or so, the overall burden following sepsis in children is increasing. And this is due to the increased survival of children with chronic complex morbidities. Over 77% of children with severe sepsis have chronic comorbid conditions. While the in-hospital mortality may have decreased compared to 50 years ago, there remains a burden of long-term mortality in children with sepsis. And this US database study demonstrated that a hospital mortality rate of 6.8% in children with sepsis. And just to put things in perspective, the mean mortality rate in children, critically ill children, is between 1.5 and 3% in high-income countries. However, the late deaths occurring after a month post-discharge was just as high as the in-hospital mortality rate at 6.5%. Therefore, late deaths following pediatric sepsis can be as high as early deaths. The main risk factor for late deaths was having an underlying chronic disease. And I think this study also highlighted an important finding in that a significant proportion of late deaths in previously healthy children were injury-related. That included suicide and overdose. And this underscores the importance of understanding long-term quality of life outcomes in children following sepsis. Sepsis and septic shock mortality in children varies across geographic regions, as we know, but the risk of late mortality, however, is reported in both high and low middle income settings. The Sepsis Uganda project demonstrated a late mortality rate of 5.5% in the 6 months following discharge, similar to the US data. Study in Rwanda demonstrated an overall mortality rate of 9.4%, with half of these deaths occurring in hospital and half of these deaths occurring after discharge. While the late mortality rates appear similar in both high and low middle income centers, the risk factors are not. The main risk factors for post-discharge death seen in these sub-Saharan African studies were young age, malnutrition, lower maternal education, and longer times to travel for care. And these highlight the importance of post-discharge and transitions in care following pediatric sepsis in different settings. We talked about mortality, but what about the burden of post-discharge morbidity in pediatric sepsis survivors? At discharge, about half of these children with sepsis require new medications, and a third require new medical devices. The risk of readmission in the first year post-discharge is high as adults, it looks like. Almost half of the pediatric sepsis survivors are readmitted to hospital, the majority occurring within the first 90 days of discharge, of whom 65% require critical care. The major risk factors for readmission to hospital after sepsis are primarily having chronic medical condition, pre-existing medical condition, young age, less than 1 year, having a congenital or chromosomal abnormality, and having a neurologic dysfunction. And what is interesting is that the primary diagnosis for the first admission after sepsis was sepsis, primarily respiratory infections. And this is true both in children with and without chronic comorbidities. 25% of children who survive sepsis develop a new or progressive medical condition within the first 6 months of discharge. And these are primarily new respiratory failure and new CNS sequelae or nutritional dependence. Again, those with chronic complex disease and younger infants experience a greater burden of risk of comorbidity progression or development. And so there is an interaction. Children with comorbidities are at the highest risk of sepsis, and sepsis is a risk factor for future medical sequelae and long-term morbidities in children. What about survivorship? So this will be interesting to compare and contrast with the adult data that has been presented before. This is an area of tremendous growth in pediatric sepsis research in the last decade, as evidenced by the increasing number of studies and recent publications across the US, as demonstrated here, as well as research from Africa, India, Europe, and Australasia, demonstrating that long-term burden of sepsis should be as much of a global priority in children as it is in adults. What this evidence tells us is that children who survive sepsis experience multiple long-term physical, cognitive, psychological, and psychosocial sequelae as adults do. These post-intensive care sequelae affect children as commonly as they do in adults. These post-intensive care sequelae in pediatrics, is known as PICS-P, do not only affect the children, but also their family members and siblings. The magnitude of these long-term sequelae, specifically in children with sepsis, is generalizable across all settings and is now supported by considerable global data. Canadian data shows us that at 6 months, 25 to 56% of children experience poor functional status, and they include non-specific symptoms as well, such as fatigue, sleep disorders, feeding difficulties. We have US, Canada, and European data suggesting that up to 44% of these children have persistent cognitive deterioration, A significant proportion of these patients continue to complain of post-traumatic stress symptoms, and about as many as a third report persistent delusions in the 1 year post-discharge. We have data from Australasia showing that there's significant high rates of difficulties in attention at school, and data from India showing that 35% of these sepsis survivors report low health-related quality of life 1 year post-discharge. What about family outcomes? Parental outcomes are intimately linked to child outcomes, and you can see that a significant proportion of parents report PTSD symptoms, depression, and half of them have persistent symptoms at 1 year. The child-parent dyad is inseparable. Hence, patient outcomes impact family, and family outcomes impact the child. And this evidence demonstrates that high parental stress is associated with longer lengths of stay and poor functional recovery in children. There's now increasing studies on sibling outcomes, and siblings of children with sepsis experience unique and significant challenges. They experience anxiety related to separation from family members, disruption from daily activities. Siblings may feel confusion, jealousy, resentment, and guilt, or blame themselves for the distress they witness. They may experience isolation and feel forgotten by family and have limited access to coping mechanisms because all the attention is on the child. And so long-term sepsis care therefore requires the care of both the patient and the family. The identified risk factors for poor long-term functional and health-related quality of outcomes in pediatric sepsis survivors include biologic risk factors such as the sepsis source and organism and severity of illness markers. I've spoken about some of the patient determinants, patient risk factors, but there are certain social determinants of health that put a patient at risk. We also have evidence of biomarker profile from the Persevere work conducted by Hector Wong that actually shows that biomarkers appear to have utility for estimating risk of long-term, persistent, or serious deterioration health-related quality of life up to 3 months post-discharge. And what about treatment? We know that time to treatment and source control impacts the risk. Steroid therapy has been demonstrated to exhibit a higher risk of persistent, severe health-related quality of life or mortality at 3 months post-discharge. The ICU-acquired complications of delirium, withdrawal, and immobilization have been shown to have high risk of these post-intensive care sequelae. There are definite risk factors related to the setting of the system, such as delayed recognition, delayed access to care, the environment, which I think, Stephanie, you talked about, and Hallie, with respect to your hospital at home. We know that harsh lighting and noise and restrictive visitor policies has significant risk factors for long-term outcomes. And the evidence has shown that a lack of an early rehabilitation bundle compared to usual care improves the risk of long-term functional and health-related quality of life outcomes. So it speaks to what you were both talking about in jumpstarting the recovery process by bringing the home and rehabilitation into the hospital with the A to F bundle. And we know that lack of home support, lack of post-discharge care, and caregiver support and school reintegration are high risk factors for poor outcomes. So we've discussed the long-term health outcomes in children after sepsis, but what about the economic burden? Direct hospital costs for pediatric sepsis has increased from $4.6 billion in 2005 to $7.5 billion in 2016. And we know that the median cost per pediatric sepsis hospitalization is 12 times the cost of all-cause pediatric hospitalizations. The short-term economic burden from pediatric sepsis is related to front-end direct costs from length of stay and medications and diagnostic tests. But the long-term economic burden, however, is primarily from indirect costs incurred during recovery, which are often 3 to 4 times higher than the direct costs. And so the true financial cost of pediatric sepsis to society remains unclear, and we do not have adequate research on long-term healthcare cost requirements in children. In conclusion, the burden of sepsis in children is long-lasting. Late deaths are as high as early deaths. Late morbidity far exceeds mortality and affects not the child, but the family. Children who survive sepsis are not affected equally, and we now have well-identified multiple risk factors for poor long-term outcome that we should now be screening for in our practice because sepsis survivors are our future patients. Our current challenges include a lack of awareness, both on the clinician side as well as the family member side. There are challenges in risk screening in children, and there's definitely a lack of follow-up programs. our current needs are not just improved early sepsis recognition programs, but early disability and intervention programs targeted at children and families to address this high burden of disease. Sepsis survivors are future patients, and hence surviving sepsis bundles should no longer be focused only on early recognition and front-end care, but also on prompting early recognition of risk factors and early rehabilitation and targeted follow-up care in children as in adults. There is no similar recommendations for post-discharge care as they do in the surviving sepsis guidelines for adults currently for children. And so sepsis recovery is a continuum of care that can adopt a chain of survival model as is used in cardiac arrest. And this chain of survival links the continuum of care from saving lives to optimizing recovery and survivorship from sepsis. So with that, I thank you very much for your attention and welcome any questions.
Wow, thanks, Karen. That was enlightening in some very powerful ways. Thank you. How do we be better about getting that message out? Right, I think there's this false notion out there that, right, kids are resilient, and clearly, right, to a degree, yes, but certainly nowhere near immune to the sequelae of sepsis that we see in adults. So how do we bring more attention to those challenges? Because clearly it needs it, right? I mean, yeah,
I think there's some of the questions that were asked before to others. The answers pertain here as well, and I think it's not just clinician awareness, but citizen awareness. I think it's although children have the reputation for being resilient, the sepsis occurs in the high-risk patients at the most vulnerable stage in their life when they're developing and their neuro cognition, etc. And so it's more, I think, at a global level awareness that it is as much an important issue in children, for example. Not to say that I think the fact that there's so many presentations focused on adults, less so in children, perhaps we could balance that global priority as well in these scientific meetings. But perhaps I'll end there. As you said, it's a very long discussion, but definitely the road has started. You asked about core outcome sets. There are now core outcome sets for children that include these important outcomes that we should be screening for, not just clinically, but in research, and trying to include these functional and health-related quality of life screening in clinical practice as well.
So note to the GSA higher-ups, right? Invite more pediatricians, right? Of course, with Dr. Kassoun at the helm, I'm sure that the pendulum is swinging that way already. Karen, thank you so much. Truly enlightening and powerful talk. So thank you.
Thank you.
On that note, I suppose I get the privilege of saying thank you to all of our experts from Argentina to Australia to Germany. To our friends to the north, thank you all. That was a great session. I freely admit I am not an outpatient post-ICU guy, so I learned a lot, and I'm humbled by the limitations of the work that we do on the inpatient and therapeutic side, and kind of reignite my awareness that sepsis is not merely an inpatient issue. It's a long-term issue. And that we need to pay as much attention to that world as we do to the inpatient world. So thank you, all of you, for your excellent talks, enlightening and really, truly remarkable. So thank you. And I see joining us to wrap up, because we just finished the last one of 15 sessions. We have the boss herself, Dr. Mariam Jashi of the Global Sepsis Alliance, to say some parting words to all of you brave souls who have stuck it out to the very, very end. Thank you all so much. And Dr. Jashi, please close the World Sepsis Congress 2025.
Nathan, thank you so much for the excellent moderation. And we couldn't thank enough all the brilliant speakers and panelists of the 5th World Sepsis Congress. We had more than 20 hours, 15 sessions, bringing the wealth of knowledge and expertise, starting from prevention, diagnostics, treatment, and post-sepsis long-term sequelae. And each of the sessions was truly enlightening, truly inspiring. And the fact that the Congress was joined by almost 12,000 registered participants from more than 150 countries is a testament to the success of our efforts. But similar to the very last talk from Dr. Choong and other colleagues, it's still difficult to understand how sepsis should not be part of every single political and high-level discourse in global health. With 50 million people affected every year, more than 11 million deaths. It's wonderful to hear increasing interest to long COVID after a couple of years of the pandemic that we all witnessed and went through. But we never hear talks or attention of political leaders to the long-term sequelae, to sepsis that has striking similarities in clinical manifestation or post-sepsis, psychosomatic or other outcomes. It's wonderful to see the increased momentum to antimicrobial resistance, but we never speak and we never hear the discussions from political leaders that the 4.95 million AMR-related deaths are only part of the 13.66 million sepsis-related deaths. And of course, through our consistent voice, through our consistent efforts and engagement of the renowned scholars, clinicians, and the brightest minds in sepsis, many of which have joined us over the last 2 days, we really hope to change the status quo. We were joined yesterday by Dr. Tedros, WHO Director General. It was an honor, and we're grateful for his continuous commitment to the Global Sepsis Alliance, including for the launch of the 2030 Global Agenda for Sepsis, that is our common roadmap. And today we were joined by Sir Jeremy Farrar, in session 8, the chief scientists of WHO. And building on his words, sepsis is a microcosm how the health systems works. And that is exactly the holistic view that we would like to focus through the 2030 Global Agenda, and how through integrated action spanning the whole cascade of prevention, diagnostics, treatment, and post-sepsis care, we can strengthen the health care systems. And with that vision, I would like to call to our participants, our experts, members, the faculty members of the World Sepsis Congress, that we continue and strengthen our efforts to position sepsis higher on the political agenda, where it deserves to be. And that is why, through the high-level political panel that we will be establishing in September, through the Global Sepsis Innovations Platform that brings multiple stakeholders around sepsis research and development agenda, through the Global Sepsis Survivors and Family Committee that was announced yesterday again under the GSA's leadership, we hope that we will strengthen our voice, we will strengthen the efforts, and make sure that sepsis truly becomes the next success story. On behalf of Tex Kissoon, Konrad Reinhardt, the Scientific Committee of the World Sepsis Congress, let me extend our sincerest and immense thanks to more than 80 speakers, 15 moderators, and 11,779 registered participants of the Congress. And my last announcement would be that Global Sepsis Alliance is currently an institutional membership-based organization, and very soon we will be opening individual membership opportunities to the GSA, and we are sure that from the 45,000 stakeholders around the world who are part of the World Sepsis movement and the GSA efforts, we will have the possibility to strengthen the unison of our advocacy and voice. I thank you very much, and for those of whom you were not able to follow every session, from April 15, GSA will publish on the YouTube and the podcast each session's recording. And you'll have the possibility to listen to our outstanding panelists and speakers. We would like to again invite our audience to join the efforts of the Global Sepsis Alliance through signing the World Sepsis Declaration and the 2030 Global Agenda for Sepsis. And of course, we thank each supporter and sponsor of the 5th World Sepsis Congress. Let us hope that next year, when we have our annual flagship event, we will come together even stronger, and despite the disrupted environment around the global health currently, we will use these challenging times as an opportunity to position sepsis even stronger. I thank you for your attention, and I thank every single member of the faculty and, of course, our brilliant team in Berlin, Marvin Zick, Simone Mancini, and Katja Kubel, who made this Congress a success. Thank you.